So good afternoon, everybody. I am Dr. Mehak Bansal. Me and my team is from SPS Hospitals, Ludhiana. And there was a lot of confusion about COVID these days. So we thought we would just have a discussion on these things. Um, I would start with my presentation first. So coming to COVID-19 in children, and this first slide of mine, basically, I want to thank all those healthcare warriors who have dealt with COVID and who have died dealing with COVID, and many of our colleagues are still in all over the country are dealing with COVID, and we've had some bad news in the last couple of months. So coming to coronavirus. Coronavirus is a family or subfamily of Coronavirinae, and we have a 4 genera, that is the alpha, beta, gamma, and delta. Not going into details, but alpha and beta are the ones who have caused human coronavirus as till now. And out of these, we've already had 2 pandemics in the past. That was the SARS-CoV-1 and MERS in 2012. And right now we're dealing with the SARS-CoV-2, which is the 7th beta type coronavirus. And as you have heard, there are 2 types of strains basically: the S type, which is the less virulent strain, which is causing the current pandemic, and the L type strain. We had things like in Gujarat, in some parts of Maharashtra, we have L type strains, and these are the strains which are more virulent and more infectious. And we all know it's a zoonotic disease which is transmitted from animals to humans. This is basically the genome, which is this looks, and it has the spikes, and that is why it is called coronavirus. Now coming to the pathogenesis, and now why this pathogenesis is really important, I would share 2 slides. One is the pathogenesis and one is the viremia and the hyperinflammatory state, to basically understand the pathophysiology of coronavirus, and then the treatment and the therapies become a little simpler. Now, as you can see, the first receptor which is in our body is the ACE receptor, ACE2 receptors, and we've also heard about TMPRS receptors. These are the 2 receptors which help the coronavirus get entry into our body. Once the coronavirus enters, it replicates, and after that, it basically activates the cellular immunity and the humoral immunity. And then comes your major problem, which is the cytokine storm. And this cytokine storm is basically the one responsible for the damage to various organs. The first hit is the lungs, and later on, it can cause hit to the cardiac function, your kidneys, and other organs. Coming to children, as you can see, this is the graph of India, and you can see the cases in pediatrics, which is 0 to 10 years and 11 to 20 years, is less as compared to adults. The good point in coronavirus is this is one of the pandemics where we have some good news, that the children are relatively spared, and most of them are asymptomatic or with mild or moderate symptoms, and they have less mortality. So far, we have got one data of China, which is of 2143 pediatric patients, and they saw that more than 90% were asymptomatic or mildly symptomatic or with moderate symptoms, and very few, that is 5.6% of them developed the severe disease. USA was also given its data that they had 1.7% of the total cases were pediatric, and only 2% required hospitalization ICU requirement, and 3 of them died. Now, why? One thing is that factors which worsen the outcomes is in younger children, is children less than 1 year. So all over the world, they have seen that the infants are badly hit, and they are the ones who are getting more sick. Any child having underlying pulmonary conditions or any immunocompromised states. And the case fatality rate is also less in children as compared to adults. Now, this is, as you can see, this is our basically data till July 9th, and you can see that less than 14 years, the death rate, the share of deaths in India is still less than, it's about 1%. Now, why are children less vulnerable to COVID-19 as compared to adults? Now, if you go back to the pathophysiology I showed you, the first receptor which allows the coronavirus to enter in our body is ACE2 receptors and TMPRS receptors. And somehow we have seen that in children, these receptors are less. They're less expressed as compared to adults. The second is the immunity of the children. The immune system in the children basically there's a less neutrophilic infiltration, decreased production of pro-inflammatory cytokines, and increased production of immunomodulatory cytokines in children as compared to adults. Another important thing is that endothelial cell apoptosis and dysfunction with the breakdown of pulmonary endothelial cell barrier leads to pulmonary edema and ARDS. This pathophysiology is less pronounced in children as compared to adults. There's a recent article that says melatonin, which is less in children as compared to adults, and that is basically responsible for the inflammatory injury. Receptors and TRS receptors are less in the pediatric age group, and they have less cytokine response as compared to the adults. Coming to symptoms of COVID-19 in children. Now, in this last couple of months, we've got many patients, unfortunately 5-6 patients, and who had fever, but they had no other symptoms. And some of the cases some other illness, and they were found to be COVID positive. Now, basically, main symptoms we know for COVID is fever, sore throat, and rhinorrhea. And the other we know is headache, myalgias, dyspnea, and shortness of breath. In children, definitely tachypnea and tachycardia is one. But these symptoms are the ones which is exclusive, or you can say more predominant in children as compared to adults. That is the diarrhea. Now this goes back to my friends and my colleagues in UK. They found some basically 18 children in Evelina Children's Hospital, UK, where they found that many children with diarrhea, vomiting, and abdominal pain, and presenting like Kawasaki disease type illness. They were found COVID positive. Not all of them, but that was the time we realized that there is some association of COVID with Kawasaki disease type illness. Since then, we have read a lot about this, and we have seen a lot of cases all over the world, close to 2,000 cases. And now some people call it MISC, some call it KDSS, that is Kawasaki disease shock syndrome, depending on the presentation. But as we see in Kawasaki disease, here also we have rash, we have conjunctival congestion, we have edema, and we have other lymphadenopathy and other things. Loss of smell and taste, definitely in adults, this is found one of the symptoms. Now, coming to when the child comes in a very critical situation, so we have found that many COVIDs, they basically, we all know that it leads to ARDS, respiratory failure. But as I said, the Kawasaki disease shock syndrome, many children have come with shock, encephalopathy, and myocardial dysfunction, heart failure, coagulopathy, and acute renal failure. I would go in detail with the MISC and the KDSS later on, but so far so good. Basically, multi-inflammatory syndrome is basically inflammation of all the organs of the body, leading to multi-organ failure that has been associated with SARS-CoV-2. As I said, gastrointestinal symptoms and the vomiting and diarrhea, they are more predominant in pediatric patients as compared to adults. So coming to the incubation period, now what is this incubation period? So if today I've gotten contact, now the main journey starts here. So today I've gotten contact with a patient who is COVID positive. So it took me 3 days after the exposure to develop the onset of the symptoms. Approximately it is 2.3 days. And once the virus inoculates into my body through the mucosa, conjunctiva, GIT tract, they gain access to the ACE receptors and they go inside my body. Now, when is the infective period starts? The infective period starts 14 hours before the symptom onset. So even like on the second day, you can become symptomatic. and then this infectivity then declines in the next 7 days. If the patient doesn't develop any symptoms, that is called the asymptomatic patient, the patient will remain infectious for the next 10 days. Now, what is this asymptomatic, pre-symptomatic? We all get confused. But as I said, 3 days is the incubation period. And after my incubation period, suppose I develop symptoms, then I am in a pre-symptomatic phase. And if after 3 days of incubation period, I do not develop any symptom and remain asymptomatic for the next 7 days, I am the asymptomatic patient. So why am I talking about this? For the healthcare workers, these asymptomatic, or for the rest of the population, these asymptomatic people are the one who have been the main culprits of causing infection. We had a survey all over the country where we have seen that those people who are taking care of the coronavirus patients, they are getting less infection, and we all healthcare workers or the population who's dealing with the non-coronavirus patients, they get more infections. And again, this is probably because because we don't identify the asymptomatic carriers. Okay, so coming to this very important diagram, and before we go on to the drug therapy, this is the gist of coronavirus. This one diagram is the gist of coronavirus. Now, if you see basically that, so if you see basically that this was my incubation period, that is the 0 to 3 days, and here I got the virus into my body. Then my body will enter, which is called the viral response phase. Now, what is happening is there in the virus is replicating inside my body. This phase is called the viremia phase. Now, in this phase of the viral response phase, I can get symptoms. If I get symptoms, I am a symptomatic patient. If I don't get symptoms, I am a asymptomatic patient, but I can still give coronavirus to many people. Now, here we develop the constitutional symptoms like cough, cold, fever, and you can have diarrhea, you can have headache, you can have other symptoms. And these are usually the mild symptoms. And here, if you get yourself investigated, so many people come to us or in our OPDs in this phase that they have developed cough, cold, fever, diarrhea, or something like that. If you get them investigated, what will you find is a lymphopenia. That is the neutrophil, lymphocytes are less and the neutrophil count is more. And if you do their LDH, D-dimer, prothrombin, they may be elevated. Now, there are certain drugs which only act, which are antivirals. And what are those drugs? Like HCQ we'll talk about a lot. That is probably, yes, that is one of the antiviral drugs. The other thing which is an antiviral is the remdesivir, and the latest drug which is the favipiravir. So these are the antiviral drugs. And if we want to give these medications, so this is the right phase where we have to give the medication, that is the viremia phase. Now, usually after the 7 days of the symptoms, that is my 7th day of fever or my 7th day of cough and cold, I basically go into the virus goes down, my viral load goes down. So the high period of infectivity is the first 7 days of my symptoms. And after that, my viral load goes down. And then you can see that the inflammatory response has started occurring. Now, here, if you go back to that diagram which I showed where we had cytokine response and hyperinflammatory response. Now, this phase is that response. So what happens? There are lots of cytokines release, interleukin 1, 6, and lots of cytokines which are causing this host inflammatory response. And usually this occurs between 7 to 10 days of your starting of your symptoms, or it can go up to 14 days. And here you develop something which is called happy hypoxia. Either you develop shortness of breath, or you develop dyspnea in children, or you develop happy hypoxia. That means you feel comfortable, but your saturations might be low. And this is the time, basically, this is sort of a pulmonary, it is also called a pulmonary phase, where we have started, the virus has gone inside from our throat, our mouth, it has gone inside our lungs, it has started troubling our lungs, and we are developing the lung symptoms. And if you do a chest x-ray at this time or a CT at this time, you will have CT changes. Now, many people, do the CT and the chest X-ray in the viremia phase, and they don't get anything, but they start getting, and if you can see that this is basically your immune response. So basically, this is has gone down, and now they have started getting the symptoms again. That means this is called biphasic fever, that is, the symptom has subsided after the 7 day, but again you start getting high fever and you start getting shortness of breath. So there's a false sense of relief that my fever has gone down, but after this phase, because we are entering into the hyperinflammatory response phase, I will start getting high grade fever, I will develop shortness of breath, hypoxia, and other symptoms. Now, if I go further beyond 14 days or 10 to 14 days, you can see there is a big hyperinflammatory response here. And this is the time where we have the highest mortality, or you can say this is the time we need intensive care units. The patient can develop ARDS, the patient can develop SIRS, the patient can develop shock, cardiac failure. And if you do the inflammatory markers at this point of time, the inflammatory markers will be very high. The CRP will be high, LDH, IL-6, D-dimer, ferritin. So what are these tests? These are basically a representation of the inflammatory markers. So your CRP, LDH, IL-6, ferritin, troponin, and so basically these inflammatory markers will increase. Now, coming to the medication at this point of time, as you can see, that my antivirals will not work in this phase. Yes, they can work somewhat in this phase, but once I've gone into the hyperinflammatory response syndrome, the work of my antivirals is gone. And what were our antivirals? Favipiravir, remdesivir, hydroxychloroquine, and even convalescent plasma is an antiviral therapy. Here comes the role of corticosteroids. Here comes the role of tocilizumab, which is the IL-6 inhibitor. And here comes your role of anticoagulation, because this hyperinflammatory response is mainly because of two reasons. One is inflammatory response and the other one is thrombosis. So coming to the same thing which I was telling before, just covering one by one, the symptomatic non-pulmonary phase where we get the symptoms. These symptoms can occur for 5 to 7 days, and after that we can become totally asymptomatic after the day, or we can stop getting these symptoms. And most of us, 85% of us, recover after this viremia phase. This is because of our innate immunity. And as I said, the only therapy which works here is your antivirals, which I have described before. Coming to the pulmonary phase, that I said by the second week, that is if my fever started, that is the day 1. By 7th day, I will start getting the virus will spread into my lungs, and I will start getting happy hypoxia, or the drop in the saturations. I may notice it or I may not notice it. And usually when we were because everybody was being quarantined before, so people used to fear being in a quarantine place. So they used to come very late, and they never used to recognize this happy hypoxia phase, and that was the time when we had lots of mortalities. Now we recognize this phase by telling the patient a simple test, that is the 6-minute walk test, that the person has to walk for 6 minutes. Before that, you do a saturation check, and after you come back, you do a saturation check. If your saturation drops by 4%, that is the time you have to basically go and do this. Now, coming to that I said that two pathological processes which are responsible at this time is the pulmonary fibrosis and the immune dysregulation. This phase, after the patient completes his viremia phase, we tell them to check their saturations at least twice a day. And otherwise, you go and do a 6-minute walk test or a sit stand test. And if your saturation drops by 4%, you have to visit the hospital. Or if your saturation goes below 94%, then definitely you have to visit the hospital. The whole focus of our treatment has now gone into the basically two phases, that is the symptomatic non-pulmonary phase and then your symptomatic pulmonary phase. So we try to give drugs at this point of time. We try to give oxygen therapy, we try to give antiviral drugs, we try to recognize the inflammatory syndrome early as possible and then treat it, and we try to give antithrombotic therapy at this point of time. So the whole process has changed. We used to focus more on ventilated patients in the last few pandemics, but now the focus is on the non-ventilated patients, those who are requiring oxygen, those who have hypoxia. There are lots of things we can do to prevent them from going into the phase which is called the I'll say a symptomatic pulmonary phase. Now, basically, as I said, the vasculopathy and coagulopathy is one of the culprits in causing the problem. And this basically vasculopathy, coagulopathy, and that can result as a result of three factors, that is reduction in the blood flow and the vascular endothelial injury and hypercoagulable state due to alterations in the blood constituents. This can lead so many patients have come with us which have pulmonary embolism. So that is one of the findings we have seen here, and we read this, and that is why the anticoagulation has played a major role in saving these patients. So coming to the hyperinflammatory response, as I said, there are a lot of inflammatory markers which are being released at this point of time. What are the anti-inflammatory point of time is methylprednisolone, IVIG, and tocilizumab. Coming to the symptomatic pulmonary phase, as I said, we can divide symptomatic pulmonary phase into two parts. Please can everybody mute themselves.
ਹੁਣ ਦੇਖੋ ਸਾਰੀ ਸਿਸਟਰ ਦੀਪ ਸਿੰਘ ਦੀ ਸਟੋਰੀ ਜੋ ਤੁਸੀਂ ਕਲਾਸ ਨੂੰ ਕਹਿ ਰਹੇ ਸੀਗੇ ਹੁਣ ਆ ਲਈ ਸਿਸਟਰ ਦੀ ਮੰਡੇ ਪਾਤਾ ਸਕੀਮ ਦੇ ਰਹੇ ਹਨ ਉਹ ਦੋ ਦਿਨ ਹਾਂਜੀ ਉਹ ਜਨਰਲ ਸ਼ਿਫਟ ਹੈ ਤੇ ਉਹ ਕਿਥੇ ਮੰਡੇ ਜੋ ਕੋਈ ਕਾਬੂ ਕੋਈ ਗੇਟ
So pulmonary phase can be divided into two parts, that is the early phase and the late phase. As I said, the early phase, our focus is all on the early phase. We try to give anti-inflammatory therapy and prevent going into the late phase, which is the classic ARDS phase. Now, case definition. Now, this comes from the MOHFW guidelines or the Government of India, and even Punjab has taken out its guidelines. Basically, while in this pandemic, everybody with fever, fever is there, to take it as a suspected case. But the case definition is basically you have symptoms of ARI, acute respiratory tract illness. If you have gone into a location where there is a containment zone, or you have been in contact with a person who is a COVID-19 case. But now this very important thing is the fever that and absence of any alternative diagnosis. So if you don't find any other infection, this fully explains the clinical presentation. And in our hospital, we are taking everybody, even because we are seeing a lot of asymptomatic patients, we are getting everybody tested when we get the admission. And more than testing, I think we should basically prevent ourselves, use proper masks, so that we get saved from these asymptomatic cases. Next is the probable case, that you thought it's a COVID, but you could not confirm it by testing, and or test could not be performed by due to some reason. And a confirmed case is easy, that you have basically a positive result of COVID-19 infection. Coming to mild, moderate, and severe. So every pandemic we have a classification of mild, moderate, and severe. Dengue we had in swine flu. So again in coronavirus, once I have identified that a patient is COVID, probable COVID or a confirmed COVID, I have to do two things. That is monitor his SpO2, his respiratory rate. And as I said, that if his SpO2 is all right, we'll have to do a 6-minute walk test. So if it is mild, the saturation will be more than 94% in the room air, and there will be no dyspnea. In case of moderate cases, if you take the saturation of these patients, they might be floating around 90 to 94% in room air, and they will be having mild tachypnea. In the severe cases, the saturation is less than 90% in room air, and more than 30 is the tachypnea. CT chest. So some people have classified this on the basis of the CT chest as well. So if your findings are less than 25%, it is grade 1, 25 to 75% findings, it's a grade 2 or 3, and the grade 4 is pneumonia has it's like 75 to 100% of the lungs. Coming to a child with COVID-19, so mild is the child who doesn't have any oxygen requirement. These are the children you will be seeing in the OPD with some cough, cold, fever, or maybe diarrhea, or maybe any of these symptoms, but they have no tachypnea, they have no other issues. So you can give the symptomatic treatment and send them home. The moderate cases, if you check the saturation, so I think in all our OPDs, we should start having a pulse oximeter, which is very, very crucial at this point of time. Even if a child comes with mild symptoms, we should check the saturation and look for tachypnea. If there is tachypnea according to the age and the child saturation is 90 to 94%, it is a moderate case. And in severe critical cases, this can occur in both children as well as adults. You can see you can develop ARDS, septic shock, altered consciousness, and multi-organ failure. The comorbid conditions, definitely, these are more predominant in the adults. But why am I talking about these comorbid conditions? I'll tell you in the next slide. Basically, any two of the following: age more than 16 years, blood pressure, high blood pressure, COPD or asthma, obesity. Obesity has been identified to be a very bad, I think, risk factor in COVID. And any one of the following, that is the diabetes mellitus, immunocompromised states, coronary artery disease, or any hepatic renal disease or pregnancy. Now coming, we get many frantic phone calls that I have got COVID positive, and now what should I do? So I think if we are mild, asymptomatic case without any comorbidity, so we have to take medication and we can do home isolation, or depending upon the place, we are doing a quarantine at the center. Because at this point of time, we should not worry that every COVID has to be admitted to the hospital. This is not, if I am asymptomatic or mildly symptomatic, and I'm not having comorbidity, there is very less chance that I would deteriorate. But anyways, we would go into the home isolation and continue checking our inflammatory markers. Our pulse oximeter should be there with us. We should get the blood samples checked every alternate day, and then take the medications, which I would tell about later. Mostly what we are giving in the mild cases is either favipiravir or hydroxychloroquine, along with AZI. This is in adults. In pediatrics, we are just giving paracetamol. Hydroxychloroquine I was, some people in Canada are giving this, but I think most of the mild asymptomatic cases, children, they usually recover. So paracetamol is the best for them along with some supplements. Coming to mild asymptomatic with controlled comorbidity. So I am mildly symptomatic, but I have a comorbidity. Suppose I'm a diabetic. So I should definitely get myself admitted in a quarantine center with a medical backup. And this is very crucial because in case of comorbid conditions, you need a monitoring. Especially if you are a layman, you definitely need a monitoring. And if I found a mildly asymptomatic patient with uncontrolled comorbidity, I should get admitted to the ward. And in the moderate cases, definitely we mostly admit these ones. Either we get mildly symptomatic with uncontrolled comorbidities, and moderate cases we admit in the ward and we start oxygen and we start steroids. Now coming to the mild cases, as I said, these mild cases usually are in the viremia phase. So viremia phase, we can try the antivirals. Either we can give favipiravir or we can give hydroxychloroquine. And if the procal is high or the CRP is high, we can give antibiotics. But in case of moderate diseases, we admit in the ward if the saturation drops by 4% or we have hypoxia, we start the patient on on steroids and oxygen. And in the severe cases, we'll talk later. So coming to the basically who should be admitted to the hospital. And if I'm in a quarantine center and I fear that my symptoms will worsen, so who are those people who can worsen their symptoms? So one is infants, age less than 1 year, and second is more than 60 years. Unfortunately, the maximum hospitalization in India has been happening in the age group of about 45-50 years of age. And but yes, this is one of the big risk factors. Fever, if my fever is persisting, as I said, it is a biphasic, it can be a biphasic illness. So you had a period of fever, your fever subsided, but then you start getting fever again, or you start getting hypoxia. So that is the time, if my fever is persisting beyond 7 days of age or onset of symptoms, and that means I have got a second spike, which is an inflammatory phase. If I'm tachypnic, that is the respiratory rate more than physiological rate, saturation more less than 90%, 94%, or if there is a drop in the saturation after a 4/4 after a 6-minute walk test, and persistent tachycardia as per the age, and poorly controlled comorbid conditions. And another problem which has been seen is the inflammatory, basically neutrophil lymphocyte ratio more than 3.5. This is not really true for pediatrics, but this is one of the risk factors which can be present and you need hospitalization. Now coming to the once this we have basically this is kept in our walls. So we monitor the patients according to this in a COVID care center, mild, moderate, and severe. As you can see here, the severe cases, the saturation has dropped to less than 90%, and the patient is tachypnic more than 30 per minute. And here we raise the alarm that something really wrong is going on. Laboratory investigations. So once you get fever, you come and you get, the first thing we need to check is the CBC. Any patient or any pediatric patient with fever and you suspect COVID, get a CBC done. Although lymphopenia is less common in children as compared to adults, but if there is a neutrophilic predominance, that is neutrophilic lymphocytic ratio more than 3.5, probably you are dealing with COVID. The second thing we can do is a CRP, and the other inflammatory markers like CPK, LDH, D-dimer, ferritin, and IL-6 levels. Unfortunately, IL-6 levels take a long time to come. So we are basically doing everything on the clinical judgment and the other inflammatory markers. Even if you don't have IL-6 and you have the other inflammatory markers raised, like suppose you have a LDH more than 500, you have a D dimer which is more than 1, or a ferritin more than 500, and the IL-6 has gone more than 80, you're dealing with a hyperinflammatory response syndrome. And that is the time you have to give anti-inflammatory drugs, which is the steroids. And the second thing you have to give is basically the tocilizumab. Now coming to the other investigations is the LFT, RFT, and in pediatric or in adults, sometimes we do, when we are dealing with a shock key situation, we have to do TROP-I or pro-BNP. So pro-BNP and TROP-I, they both basically indicate the cardiac involvement. And in Kawasaki like disease in children, as you do in normal Kawasaki disease, that you measure the triglycerides, ESR, and fibrinogen. And HbA1c is very important in adults to identify diabetes, which is a very poor prognostic marker. Most investigations, they're like CBC is the thing which you can repeat daily, but the other inflammatory markers you can repeat every third day. Interpretation of results. Now, why am I doing D-dimer, CRP, IL-6, ferritin, LDH? So suppose if I'm admitted and I have, you can see that my CRP is rising, my IL-6 is rising, ferritin, LDH, they all indicate hyperinflammatory response. This is the time when your antivirals will not work. So this is the time you have to get anti-inflammatory drug. And the most common anti-inflammatory drugs we are using and everybody's using is high dose is steroids, and the second one is the tocilizumab. If the ferritin is out of proportion, that is more than 4,000 with deranged LFT, and you have pancytopenias. So if it is very important to differentiate between hyperinflammatory response syndrome or a macrophage activation syndrome or a HLH type picture. Like if your ferritin is out of proportion and your LFTs are getting deranged and you develop pulmonary neurological symptoms along with cytopenia and you see all the cell lines are reducing, you should consider macrophage activation syndrome or HLH at this point. This is because here you will have to use steroids in view of macrophage activation syndrome. Coming to the chest x-rays. So we've done the laboratory investigations. My next thing is the chest x-ray. Now, we get many x-rays asking that, is it COVID? Is it COVID? So even if the x-ray is normal, it doesn't rule out that the patient is not having COVID. That patient may be in the viremia phase or the early phase, and the virus has not gone inside the lungs. So that is the phase. If you do an x-ray at that point of time, you might not get any changes, and a negative chest x-ray does not mean the patient doesn't have infection. Coming to if in a moderate phase where patient has started getting lung in the pulmonary phase, you start getting these symptoms. Now this is the classic of a COVID x-ray which I have picked up, and as you can see, there are three main important things here. One, lower lobe predominance. So most of the infiltrates are basically there in the lower lobes. Number two, there is peripheral predominance or the peripheral grounding. As you can see that certain angles are not clear, and mostly the infiltrates are kind of glued to the pleura. So this is also called a reverse bad sign. So instead of the infiltrates going out, they usually infiltrates kissing the pleura, and the basal zones is the predominant areas where you will find these ground glass opacities. And they can be multiple ground glass opacities with or without peripheral consolidation. So three things, as I said: lower lobe predominance, peripheral grounding, and bilateral ground glass opacity with or without peripheral consolidation. Now, there are certain cases where X-ray doesn't fit the classical chest X-ray, or you have a long patient, like I had a patient with thrombocytopenia We did find out there was right effusion and deletion. So, pneumothorax, lobar consolidation, pleural effusion, and pulmonary edema. These are not the classical pictures, and they probably are not COVID. These are the three X-rays which I have pulled out. X-rays I have pulled out. Same one I was talking about. Other X-ray, you have seen that this patient has gone into some pulmonary with lots of bilateral ground glass opacities, and there you can see the air bronchograms, the bilateral ground glass opacities, and this is a bad X-ray. And here you can see the round opacity. Usually it is present in pediatric pneumonias, but yes, you can have round opacity in case of. Let's see the CT scan of these patients. And many times we have seen that the X-ray looks normal, but when we do a CT scan, we get certain hints. Now here, if you see closely, here an opacity has started appearing. Here, the opacity has started appearing. What is important about this CT scan? The peripheral grounding, and you can see that the lower lobes and there is a low down peripheral grounding. Coming to the next.
Start video कर दो ना पापा.
You started having some peripheral opacity.
Mute कर दो. मैं बोल दी भी लड़की. आपने बोलो. Question answer है.
Started getting some peripheral opacity. The early stages where you start peripheral opacity. Please everybody mute yourself. And the last one is basically this CT, where you can see now the opacities have become multiple. They have involved the bilateral lungs. And so what is typical in this? You have a ground glass opacities. One, they can be with or without consolidations. They have a predominance to go in the lower lobes, bilateral involvement, and as you can see, they're abutting the pleural surfaces. Now this opacity is abutting the pleural surfaces. So basically they are glued to the pleura at many parts of, this is classical of COVID-19, and sometimes you have a central round clearing. So these are the CT scans. Coming to the X-ray versus CT scan. So this is one of the X-rays of my, basically my friend who had a X-ray which didn't show anything. And after that, you can see that she got her CT scan done. So the X-ray looked pretty normal. She started having fever. And after a while, we realized that she's got some peripheral grounding here. And this person, the COVID was also negative. So here are the peripheral groundings we can see in this. So yes, if your COVID is negative, your X-ray is negative, you still feel that your child that whom you are dealing with can have COVID, you have to go for a CT scan to diagnose these peripheral opacities. Definitely they are picked up more on the CT scans as compared to the chest X-rays. Also, we do lung ultrasounds, and what you can see in the lung ultrasound is the lots of V lines, subpleural consolidations, which has been seen in the classic in case of AR, in case of COVID. And these irregular pleural line and the subpleural consolidations and irregular areas of V lines, these are the things which are being seen in COVID, and they've also started classifying COVID on the basis of lung ultrasound scans. Coming to, so we've gone through the laboratory investigations. We've seen that chest X-ray can be negative, your RT-PCR can be negative, your CT can still show findings, and many of our, many of people are being identified using CT scan because they pick up these small peripheral opacities which are there. Now, what is the problem with the real-time RT-PCR, which is the gold standard for detecting COVID-19? No doubt it is the gold standard test and it has got a good sensitivity and good specificity. But many a times I see COVID negative reports. This is because you have the technique of taking the sample. It is very, very crucial. It has to be nasopharyngeal as well as a throat swab. So it has, we got 2 sticks in that tube, and one we have to take a nasopharyngeal, one swab we have to take a throat swab, and both should be sent. The second thing is the cold chain has to be maintained. If you, most of our tests go to Delhi, and so there might be a breach in the cold chain. The BAL is more sensitive, bronchoalveolar lavage, but it is not being used because of the aerosol generation. It is a good test, even it detects less than 10 copies, and it has a good sensitivity and specificity and a good turnaround time, 6 hours. So it is the gold standard, but there are certain problems associated with it. So proper sampling is very, very important. Second, storage and transport of the sample is really, really crucial. And so these are the things we need to monitor when we are doing. And there's certain, depends on the kits also and the person who's doing it also. So there's some fallacies, but overall it has been a reliable and a good specific test. Coming to the antigen detection test. Now many people come and they ask that should we go for an antigen detection test? So antigen detection test is good test. It can identify, like dengue rapid antigen test, it can identify the infection in a very small period of time. And but the problem here is that if the test come negative, you have to get it confirmed with a real-time PCR test. So government is not really allowing that if you get a negative test and you have symptoms, you have to go for a PCR test. So we are directly going into the getting the PCR test done. So it is being used definitely in by the health, by government in symptomatic and asymptomatic patients in the containment zone and healthcare workers, but not in isolated. They are using it with the RT-PCR. Coming to IgG antibody detection test. So IgG antibodies start appearing after 2 weeks of infection. And once the individual has recovered, they may last for about, some people say 90 days and some people say more. We don't know much, but the IgG test is not useful for detecting the acute infection. And it is being used only for the surveillance purposes in the vulnerable population. So in our hospital, we've all got our IgG tested. This is just to find out who has got the infection in the past and now has recovered. Coming to the therapies, so we know lots of therapies, and we briefly I've discussed the therapies with the diagram where I showed the viremia phase and the hyperinflammatory phase. Now coming to the one major point in COVID. So most of the people, they are dehydrated. I don't know, we have found that basically overzealous use of furosemide and hypovolemia causes AKI or acute kidney injury in these patients. So adequate hydration has to be maintained in these patients, and even if it is a severe case, conservative fluids have to be given. The role of the best is the paracetamol for fever, and the other supplements like vitamin C, zinc, vitamin D. We have not got any constructive evidence, but they are the supplements that can be given to the patients when they present with COVID. Coming to hydroxychloroquine, as I said, there has been a recent study which says, yes, you can give hydroxychloroquine, but only in the viremia phase. And if you give in the severe cases or the moderate to severe cases, this is not really helpful. Anyways, we are giving either hydroxychloroquine or favipiravir, and people are generally intensivists, adult intensivists are using hydroxychloroquine or favipiravir. The problem with the HCQ is you can't monitor the ECG at home, and it is definitely found to cause some ECG changes. So the dose is 400 milligram. In the treatment dose is 400 milligram twice a day, followed by 200 milligram twice a day for 4 days. And if after 5 days, so this is the treatment dose for 5 days, and after 5 days, if your fever is still persisting, you can continue hydroxychloroquine for another 5 days. The other medicines have been proposed is the ivermectin and doxycycline. Don't have much experience about this, but if your procal is high, or you have your CRP high, they give azithromycin. In pediatric patients, most of the mild cases we are treating with paracetamol, and if we think that there's a procal is high or CRP is high, we give azithromycin. Coming to the favipiravir, so this is a drug which has come recently. One good point about favipiravir is the ECG changes and the monitoring is less tedious with favipiravir as compared to the hydroxychloroquine. Anyways, we do not have still much conclusive evidence about this, but the thing is that it has been seen that if it is given to mild to moderate cases of that is in the viremia phase, that is within first 10 days of onset of the symptoms, it causes reduction in the viral load and provides symptomatic and radiological improvement. So what is the dose? The problem with this is 9 tablets. So 9 tablets twice day on day 1. Many of the patients who have been admitted in adult intensive care units, they have refused taking favipiravir because of the number of the medicines they have to take. So 9 tablets twice a day on day 1, followed by 4 tablets twice daily for about 14 days. So this is favipiravir. The other drug, remdesivir, this is one of the antiviral drugs which has some conclusive evidence about this. And to be very honest, I talked to many people in Delhi, in UK, and even in US. So coming to the remdesivir, they said that first of all, the choice, patient selection in remdesivir has to be very, very important. So the first thing, it is an antiviral drug. So it has to be given within the first 10 to 12 days of the symptoms onset. The second important thing is that what they say is if you have early pneumonitis sort of a picture, and you've done all your blood tests, there is no hyperinflammatory response, that your CRP, your ferritin, your D-dimer, etc., but you're having hypoxemia, you're requiring HFNC, or you're going into the ventilation phase, remdesivir can be tried. And the dose, as I said, is 200 milligram IV OD on the first day. And after that, you give it OD for 4 days, total of 5 days. And even for some people who have not recovered, they continue it for the 10 days. So till now, what indication which has been understandable in this case is basically viremia phase for remdesivir. The second important thing is give it in early case of pneumonitis when you're not having a hyperinflammatory response syndrome. And if you give it in hyperinflammatory response syndrome, it's not going to work. So patient selection and the time selection, that is the first 10 days, is very, very crucial. And it is being avoided when you're giving steroids. So we are preferring steroids more as compared to remdesivir. Coming to the, basically this is what the landmark trial, which is the recovery trial done in UK. After this, things have, protocolized a bit. So they found that low-cost dexamethasone reduced the death rate by about 1/3 in the hospitalized patients with severe respiratory complications of COVID-19. So after that, we intensivists used to use dexamethasone more after a patient used to get ventilated. Now the change has come that we've started using steroids as an anti-inflammatory drug when we suspect that a patient has gone into hyperinflammatory response syndrome, the best indication is that if you suppose you had on oxygen, you definitely earn a steroid. You have to start steroids in that patient. But if you are having happy hypoxia, that is your saturation has fallen by 4% on a 6-minute walk test, we start 6 milligram OD oral dexamethasone to the patients. You can also give methylprednisolone. So dexamethasone basically it is not used in mild cases. In mild cases, actually it can be harmful because in viremia phase these drugs can cause problems. But in case two indications, either you have a happy hypoxia or you start getting oxygen requirement, your saturation is low, you are suspecting a pulmonary phase, start or a hyperinflammatory phase, your inflammatory markers are up, start steroids. IV dexamethasone can be given, or low dose methylprednisolone, that is 0.5 to 1 milligram per kilo, can be given for 5 days. And if you go into a severe phase of disease, the dexamethasone, the methylprednisolone can be increased from 1 to 2 milligram per kilo per day. But keep a watch on your clinical markers, your infective markers. Anticoagulation. So after steroids, another drug which has made some difference. So I'm not talking about hydroxychloroquine, favipiravir, which does not have much evidence right now, but steroids definitely have made a difference in the treatment of COVID-19. And the other drug which has, so it's a drug now, anticoagulation has made a huge difference. So as soon as the patient comes in the moderate disease, you start enoxaparin, or you can start deltaparin, and 40 milligram subcutaneous OD, or deltaparin to 2500 units international unit subcutaneous OD. And you keep checking your D dimers. So if the D dimer is basically titrate the dose as per the value of D dimer. And if your D dimer is rising, you have to increase the enoxaparin dose, or you have to increase the deltaparin dose. So if you have a risk of bleeding, yes, you can you should not give heparin. But or if your surgery is planned, or the platelets are less than 20,000 and fibrinogen level is less than 0.5, but even if there is a prolonged PT-PTTK, that is not a contraindication to the low molecular weight heparin. This basically, the hyperinflammatory response, one of the major factors is the coagulation. So basically this anticoagulation helps to tide out that period of time. And we have even gone up to further doses because after monitoring the D dimers. Oxygen therapy. So this third, which is the main therapy along with steroids, anticoagulation, is the oxygen. So identify happy hypoxia. Again and again, I'm emphasizing because this is the thing which is missed. Start oxygen not by the nasal prongs, prefer a non-rebreathing mask. And so even I was listening to a talk from AIMS, and they said they were not used to using HFNC high flow nasal cannula in adults. Mainly HFNC is being used by the pediatricians. But now, because all our focus is to avoid intubation, all over the world they have seen that if 10 patients, this is approximate, but if 10 patients are getting intubated, probably one might survive. So the whole focus is on the patients who are not intubated. People have been using NIV for 2 to 3 weeks, and HFNC has been preferred. Now, why HFNC is sometimes preferred is even, I'll talk about proning. So awake proning is quite easier when you have a HFNC, and all the pressure source and it is less claustrophobic. It is more comfortable to use HFNC as compared to NIV. And you can use if you use an HFNC, you can apply a surgical mask or N95 mask over it. So avoid intubation, avoid nebulization, and rescue therapy. To prevent intubation, you have to use rescue therapies like awake prone ventilation, anti-cytokine drugs like the tocilizumab. Now this is proning. As you can see, proning is very common part of the pediatric ICU. We do a lot of proning, but that was on the ventilated patients. Now it has been seen that such bad X-rays or such bad CTs, basically that oxygenation is better when you have a on proning. There has been meta-analysis on this in ARDS patients, but now we are, even if you are coming with mild oxygen or no oxygen, we ask the patient to be on some oxygen to prone, basically do the awake proning. Now, how does it start? So basically 30 minutes to 2 hours on the belly, 30 minutes to 2 hours or 3 hours on one side, again 30 minutes to 3 hours on the other side. So, and again go back to the position 1, and 30 minutes to 2 hours while sitting up. Now don't do awake proning if you have an unconscious patient, or you have seizures, or you have a raised ICP, or you have morbid obesity. But otherwise, if you earn oxygen or you earn steroids, we start awake proning. Along with that, with the patient, we give them this chart and tell them to perform these maneuvers while he is on the bed. Coming to the rescue therapies, I am going to speak about only one rescue therapy, that is the tocilizumab, which has actually made some kind of difference in our treatment protocols. The other are the itolizumab, high-dose corticosteroids, plasma exchange, and anakinra. But let's talk about tocilizumab. So tocilizumab. Now, what is tocilizumab? It is a IL-6 inhibitor. If you go back to my first graph, again I said that any drug you give is just understanding the pathophysiology of COVID-19. So the cytokine storm, when you have got into the hyperinflammatory phase, and how will you identify? One, the fever has started rising again. Along with the fever, you have started having more, your inflammatory markers are rising. As you can see, the CRP, the ferritin, the D dimers, they have started rising. If you get an IL-6 level, that's fine. If you don't get an IL-6 level, but if you're having worsening respiratory distress, high-grade fever, increased oxygen requirement, you're suspecting cytokine storm, you have to give tocilizumab. The dose is 4 to 8 milligram per kilogram as a single dose, and it can be repeated after 12 hours in a patient who remain febrile within 12 hours of the initial dose. Now you have to rule out any systemic bacterial or fungal infection before you start tocilizumab, otherwise we can get into trouble. In UK, when we used to give tocilizumab, we used to put the patient in an isolation room and take proper precautions, so that, because it causes harms the immune system of the patient. So you have to be very, very careful, maintain asepsis in these patients, handle their central lines and oxygen therapies in a very proper way. Otherwise, they can catch infections. So we used to isolate them in an isolation room. Here also we do that, and minimal entry of any of the coming to the convalescent plasma therapy. To be very honest, I have no experience of this, and even our intensivists, not many people have used the plasma therapy. One thing I need to specify in this: number one, it is an antiviral therapy. It will not help in cytokine storm. So again, like remdesivir, it has to be the initiation, the presentation, the time, again, is very, very important. So convalescent plasma therapy has to be given below the 10 days of symptoms. Number one, you have to check the IgG level of the patient. If not detectable, then plasma should be given. But there are lots of ifs and buts for the donors. But overall, one thing I would like to tell about the donors is that minimum after 14 days after the negative PCR, you should be like, if suppose on April 1, I became negative for the RT-PCR, I can donate on April 14th or 28 days after, basically. So if I got, if I don't want to get RT-PCR checked, 28 days after my infection, I can donate plasma. And basically, these are the things. But there are lots of problems, like 18 to 60-year-old weight should be okay. No more comorbidities, male nulliparous females recovered from COVID-19 for minimum 14 days. So you should be minimum 14 days COVID-19 recovery. So, and the dose is 4 to 13 ml per kilo. Usually we give a 200 ml single dose, and another dose can be repeated after 24 hours. So it's again an antiviral drug. And I would come back to this graph again, because this graph is the crux of the entire COVID scenario. And as you can see here, the antiviral drugs are favipiravir, remdesivir, hydroxychloroquine, and convalescent plasma. They would be useful only in the viremia phase within the first 10 days of illness. Once, monitor for your inflammatory markers, monitor for the shortness of breath, happy hypoxia, and once you go into the basically the inflammatory response phase, we have anti-inflammatory drugs like the corticosteroids is very, very crucial. Anticoagulation, they have changed the game a lot, and tocilizumab. So a monitoring of the patients in this phase is really, really crucial. These are basically the doses in pediatrics. Don't want to go in detail. Basically, these are the doses in pediatrics for the steroids, remdesivir, anticoagulation steroids. I can share it with you later on. So drugs, antiviral are remdesivir, favipiravir. Immune enhancement is convalescent plasma, and anti-inflammatory is corticosteroids, interleukin receptor antagonist, that is the tocilizumab. And interleukin 6 inhibitor, that is the tocilizumab. It can be given from day 5 to day 20. Weaning. So if I've started taking hydroxychloroquine or favipiravir, so if my fever is persisting beyond 5 days, I continue taking that for another 5 days of hydroxychloroquine. Favipiravir we give for 14 days. And basically you should have, if you get steroids, do not taper steroids all of a sudden. It can cause a resurge of the symptoms. So you have to shift the patient to oral steroids, and then you taper over the next 5 days. So it has to be really slow. And if the patient, next is anticoagulants may be continued 2 weeks after discharge. And the other thing is, when I get discharged from the hospital. So first is 10 days in case of mild cases, 10 days from the symptom onset. So August 1st, I got the symptoms. And if I remain afebrile after my 5 days, I get a discharge on the 10 days. So minimum is 10 days. Suppose on the 8th day, I was still getting fever. Today is August 8th. I am still getting fever. So I would have to wait till the time I have been afebrile, no fever, no breathlessness for 72 hours, and no drop in saturation for less than 90%. And then I would get a discharge. If everything is okay, I get a discharge 10 days from the symptom onset, and the RT-PCR is not required. So initially we started with 14 days, and now we've come down to minimum of 10 days of the admission criteria from the onset of the symptoms. And severe cases, again, 72 hours is the criteria, whatever time it takes. Some people even take 2 to 3 weeks to recover. So after the clinical recovery, RT-PCR should be done in such patients. If the swab is negative, you can transfer to a non-COVID ward if the clinical recovery is delayed. Last is the PIMS-DS. So as I said, in about, I think it was, I think April, May, when UK started seeing a load of Kawasaki disease-like symptoms in children with fever, erythema, lymphadenopathy, edema, and all these stuff. And they found that they were associated with Kawasaki disease. So they have basically, I will share, this was published by Evitan, who was the first one, and they found that this is associated with coronavirus, and not all were COVID positive, but had some association with coronavirus. And this was one of the presentations they published in Children. And then we got to know. So after that, now the RCPCH has given a case definition of coronavirus. Now what is PIMS-DS is polyinflammatory, basically multisystemic syndrome, temporarily associated with SARS-CoV-2. That means the patient will have fever, will have inflammation in terms of neutrophilia, CRP, and basically lymphopenia. multi-organ dysfunction. So you can have shock, you can have cardiac dysfunction. So many of these patients come with cardiac dysfunction, that is low cardiac output. They can have renal, gastrointestinal or neurological symptoms as well. So here was the one we basically saw that the gastrointestinal symptoms were coming more commonly in children as compared to the adults. So any child with abdominal pain, vomiting and diarrhea should be evaluated for COVID-19. And this fulfills the criteria for Kawasaki disease. And SARS-CoV-2 can be positive or negative. These are the symptoms. And as you can see, the abdominal pain, diarrhea, vomiting is one of the symptoms, and it has been one of the major symptoms in Kawasaki disease presentations. What do you need? You need to do a CR, a Procal, a ferritin, D-dimer, and do a CR. After that, you can see that you can do inflammatory markers like LDH, triglyceride. And next is you have evaluation for the echo and the ECG. So echo, most of these cases, what we have seen, they do not have coronary artery dilatation. They usually have low cardiac output functions. They have a cardiac dysfunction. They can have myocarditis like picture with pleural pericardial effusions. And usually they have, what they have reported is that the coronary arteries were hyper, really visualizing than usual, but they were not coronary artery dilatations. And ECG, you can have arrhythmias and ST segment changes. Other than that, this is the treatment protocol. Now you will ask me, how will you differentiate KDSS from MIST? Some people in MIST, basically, it is a multi-systemic inflammatory response syndrome. Basically, you have shock, you have acute kidney injury, you have multi-organ dysfunction. In KDSS, they can just with basically shock. So in that case, you have to identify this patient with a KDSS or MIST. The treatment of choice is IVIG, that is 2 grams per kilogram of IVIG, which has to be given over 12 to 24 hours, followed by aspirin. If there is no coronary dilatation, you can give a normal dose of aspirin. But if there is a coronary artery dilatation, people in UK have used 50 milligrams per kilogram of aspirin in the beginning for 48 hours and then tapered the aspirin. And coming to the hyperinflammatory MISC, again, the treatment is the IVIG. So any child who has basically such symptoms, this is one of my colleagues in Delhi has sent these pictures to me. And this is basically, you can see there is edema, there is erythema, there is basically conjunctival congestion in this child and oral erythema. And this child came out to be SARS-CoV-2 positive and was treated with IVIG. And this is the paper from Evelina, where they saw that the fever, rash, conjunctivitis, and GI symptoms were the main symptoms. And they did D-dimer, pro-BNP, and TROP-I. So TROP-I and pro-BNP, they are raised. They suggest myocarditis-like picture or the cardiac dysfunction. So they have to be treated with IVIG. And the bright coronary vessels were seen. And as I said, the treatment is IVIG, which they have given in all the patients, along with antibiotic cover and vasopressors, because most of them were with the warm shock. So they gave norepinephrine in those patients. We learned it the hard way. We had a patient with diarrhea, and then we had a patient who was megaloblastic anemia, came with just fever. So we kept them in the normal ward and they came out to be COVID positive. So the crux of the story is any fever should be, or any diarrhea, any symptoms should be, you should look for COVID. You should have a holding area. If you want to admit such patients, you should have a holding area where you have a negative pressure room. Basically what we do is the circulation goes outside of the building. There is an inflow of the air, but the exit of the air is basically outside of the hospital. So you can make such provisions in your institutes, and you can keep patients in that holding area, get a COVID done. If they are negative, you can shift them to the normal ward. If they are positive, they should be shifted to the isolation rooms. We've learned it the hard way after, and this is one thing we've learned from this. And the children, they usually develop mild to moderate symptoms. Mortality is low. Treatment is much more protocolized now, and we should understand the pathophysiology first to understand COVID and recognize PIMS-TS, KDSS, or MISC. Thank you so much. And